Harkins. This is a presentation on Alzheimer's disease awareness. This is for class EXS 486, exercise prescription of special populations with Professor Dr. Reed at Westchester University of Pennsylvania. So a lot of us have heard of Alzheimer's before, whether from a family member experiencing the disease or a friend having a family member experience the disease, or just through common knowledge and common articles we have read. But what really is it? So Alzheimer's disease, also known as AD, is the most prevalent form of dementia, which is a decline in cognitive ability that interferes with one's daily living. AD is a progressive neurodegenerative disorder affecting millions, both on a cognitive and behavioral level. Late onset AD accounts for 2/3 of dementia cases for those 65 and older, while early onset accounting for only 5% of AD patients. AD affects memory, comprehension, language, attention, reasoning, and judgment. While AD does not directly cause death, it significantly raises one's vulnerability to other complications such as pneumonia, giving AD the ranking of the 7th leading cause of morbidity in the United States. So basically, Alzheimer's is one of the most common forms of dementia in the United States, which is a progressive neurodegenerative disorder affecting millions worldwide. When it comes to disease testing and classification, there are numerous biomarkers for specific and early diagnosis. They include neuroimaging markers obtained via amyloid tau PET scans, cerebrospinal fluid testing, plasma markers such as amyloid tau and phospho-tau levels. So with the cerebrospinal fluid testing, what that is measuring, it's levels of proteins in the fluid to identify changes in the brain. And it's usually performed via a spinal tap. And then with the PET scans, you're measuring neurofibrillar tangles within the brain. And we are going to go into neurofibrillar tangles in a later slide. With classification based on a level of cognitive impairment and disability experienced by the patient. Dementia stages are further divided into mild, moderate, and severe stages, as you can see on the chart located on this slide. Some of the common symptoms a patient with Alzheimer's disease may experience include episodes of short-term memory loss as an initial and most common presenting symptoms. Difficulty retaining new information while still recalling long-term memories. Difficulty with problem solving, judgment, executive function, and organizational skill impairment. Struggle with tasks requiring multitasking and abstract thinking. Tasks such as driving, financial management, cooking, and detailed activity planning are affected in the early stages. Signs of cognitive decline are followed by language disorder and impaired visuospatial skills. Neuropsychiatric symptoms include apathy, social withdrawal, disinhibition, agitations, psychosis, and wandering are common in the moderate to late stages. Dyspraxia, olfactory dysfunction, sleep disturbances, extrapyramidal motor signs like dystonia and akathisia and Parkinson's symptoms occur late in the disease. Following this, the patient could experience decline in primitive reflexes and incontinence, leading to total dependence on a caregiver. So as one can see, a patient dealing with Alzheimer's disease has a very long progression with that disease, where they are getting worse and worse and worse as time goes on, completely losing their identity and their ability to live as a functioning adult in society, relying solely on others and caregivers to go through daily living activities. When it comes to the etiology of Alzheimer's, AD is a gradual and progressive neurodegenerative disease caused by neuronal cell death. The degeneration usually first occurs in the entorhinal cortex within the hippocampus, which is responsible for memory, time perception, and navigation. There are numerous risk factors for the disease. The leading RF risk factor is age. The prevalence of AD doubles every 5-year increase within age, following the age of 65. Cardiovascular disease is a significant risk factor, increasing the potential of developing AD and dementia via strokes or vascular dementia. Obesity and type 2 diabetes is also a risk factor. For chronic hyperglycemia can lead to cognitive impairment due to accumulation of beta amyloid and neuroinflammation, further triggering the release of pro-inflammatory cytokine and promoting insulin resistance. Other risk factors include traumatic brain injuries. This is referring to a reoccurrence in TBIs, depression, cardiovascular, and cerebrovascular disease. Higher parental age at birth. This is typically referring to the mother's age. Smoking, family history of dementia, and increased homocysteine levels. There are numerous genetic factors associated with Alzheimer's as well. A first-degree relative with AD increases the risk factor by 10 to 30%. Having 2 or more siblings with LOAD, late onset Alzheimer's, increases risk factor of AD by 3-fold. The presence of the APOE E4 allele also increases the risk factor. This is due to an apolipoprotein, which is a lipid metabolism regulator with an affinity for beta amyloid protein. In the E4 allele of the APOE gene has been identified as a significant genetic risk for late onset Alzheimer's. Further, an extra copy of chromosome 21, the chromosome responsible for Down syndrome, is at an increased risk due to higher levels of APP, amyloid precursor protein, increasing production of the amyloid beta peptides. 40 to 80% of Down syndrome patients experience AD by their 5th to 6th decade of life, and 100% of them experience AD pathology such as amyloid plaques and neurofibrillary tangles. As a autosomal dominant disorder linking 3 mutations, the AAP gene on chromosome 21, presenilin 1 on chromosome 14, and presenilin 2 on chromosome 1 also increase the genetic risk factor of Alzheimer's. When it comes to the histopathology of Alzheimer's, there are numerous factors. Neurotic plaques, characterized by amyloid beta peptide deposits on the brain, surrounded by enlarged axonal endings. Neurofibrillary tangles, abnormal protein clumps that form inside neurons. With AD patients, the protein tau that usually stabilize the microtubules and help transport nutrients and molecules detach from microtubules, clumping together, harming the communication between neurons. Critical neuronal degeneration. When occurring in a patient experiencing AD, the patient experiences cortical layer degeneration and degeneration of the hippocampal pyramidal neurons, causing brain cells to die. BRAC and BRAC staging. A neuropathology system used to classify the progression of AD through analyzing the accumulation of neurofibrillary tangles. Accumulation of amyloid beta peptide within the intracranial blood vessels can lead to cerebral amyloid angiopathy, CAA. Presence of CAA in AD is associated with more severe cognitive impairment, and a possible faster decline. As you can see on the right of this slide is a visual representation of the brain deteriorating through each stage, progressively becoming more and more deteriorated, where the patient is unable to function. When it comes to the assessment of past medical history for an Alzheimer's patient, there are numerous factors to include, such as assessing functional abilities. This provides insight of the patient's cognitive and functional status and provides the physician with a baseline assessment. Obtaining information about onset, pattern, medical history, and tempo of disease progression. Social history. This includes asking the patient if they once were or still are a smoker, along with if they had a substance abuse problem with drugs or alcohol at one point in their life. And as discussed on a previous slide, medical imaging, genetic testing, and cerebrospinal fluid analysis. It's imperative to continue assessment of the patient as the disease progresses to help evaluate the extent of cognitive decline. When it comes to treatment for Alzheimer's, there are numerous pharmaceuticals available. Cholinesterase inhibitors function by increasing levels of acetylcholine, a neurotransmitter assisting with nerve cell communication, learning, memory, and cognitive function. Side effects include gastrointestinal symptoms, bradycardia, and syncope. Amyloid targeting immunotherapy drugs are becoming increasingly common as well, with numerous versions in the FDA pipeline to be passed. This is per NCBI 2024 article. Accompanying symptoms common with AD include anxiety, depression, and psychosis. Medications used to mitigate these conditions should be done with caution, considering tricyclic antidepressants can worsen cognitive impairment due to their anticholinergic activity, which is a process that reduces the effects of acetylcholine. Further, you should avoid benzodiazepine as they may worsen delirium and agitation. Other factors that reduce risk are a higher education. This is due to the constant learning required with a higher education. Estrogen in women, anti-inflammatory agents, reading, playing musical instruments, and a healthy diet, along with regular aerobic exercise. Further, quality of life is a good treatment option as well. Creating a familiar and safe environment can be ease to the patient. Addressing mild sleep disturbances can improve their quality of life as well. Exercise. Regular physical activity can improve cognitive function, reducing the risk of falls and enhancing the ability to perform daily living activities. Studies suggest moderate to high intensity exercise may offer greater benefits than lower intensity activities. Older adults with higher cardiorespiratory fitness have lower rates of cognitive decline over 6 years than individuals with lower cardiorespiratory fitness. Dietitians play a key role in assessing nutritional needs of an AD patient. Address eating difficulties such as loss of appetite, difficulty swallowing, and texture modifications. They are also essential on assuring proper nutritional intake, such as fruits, vegetables, and protein, to assist with antioxidant intake, maintaining a healthy weight, and hitting macronutritional values. Further, healthcare professionals are a huge role in the treatment plan, such as physical therapists, nurses, caregivers, clinicians, pharmacists, social workers, mental health specialists, and dietitians all play a critical role in the management of an AD patient. Diet plays a huge role in the onset and mitigation of Alzheimer's. A healthy diet can play a significant role in preventing Alzheimer's disease. Diets rich in antioxidants, healthy fats, vitamins, and minerals can support brain health. For example, the Mediterranean diet is a diet that emphasizes fruits, vegetables, whole grains, fish, and healthy fats like olive oil. It has been associated with a lower risk of cognitive decline. The DASH diet is the dietary approach to stop hypertension, which is rich in fruits, vegetables, and low fat dairy and low in saturated fats. Can also support brain health. Antioxidants. Foods high in antioxidants such as berries, nuts, and leafy greens can help reduce oxidative stress and inflammation, which are linked to Alzheimer's. Vitamins and minerals. Leafy greens, nuts, and seeds are rich in vitamins E and C, as well as minerals like magnesium and zinc, which are essential for maintaining cognitive function and protecting against neurodegenerative disease. Polyphenols, such as green tea and dark chocolate, red wine, contain polyphenols, which have neuroprotective properties. Omega 3 fatty acids, such as salmon, walnuts, and flax seeds, are crucial for brain health. And then curcumin, found in turmeric. Curcumin is anti-inflammatory and antioxidant properties. It may help reduce the buildup of amyloid plaques and improve overall brain health. On this slide, we are going to look at a case study of a patient and then discuss a plan of action. This is a case study for patient A. Patient A is a 70-year-old male who was diagnosed with Alzheimer's at age 67. Patient has no family history of dementia nor Alzheimer's, no history of smoking or substance abuse, was classified as obese from age 45 to 50, but today appears healthy and fit considering condition. Patient A has had a caregiver for the last 3 years due to no family in the area, has a moderate level of Alzheimer's. Behavior patterns are moderate, showing little signs of aggression, but no depression or anxiety. Has difficulty sleeping, suffers short-term memory loss, and moderate long-term. Is currently on no medications or exercise plan. A plan of action for this patient would be to 1. Design a 4 to 5 day exercise routine for patient following the FIT principle. Patient should exercise for a period of 45 minutes minimum. Intensity should be moderate to high. Aerobic exercises such as cycling, elliptical, and the incline treadmill 3 days per week, with anaerobic exercises such as dumbbells and machines mostly, performed 3 days as well within that 3 to 4 day plan. Implement balance and hand-eye coordination drills in the exercise plan. Recovery in the workout as well, consisting of the sauna for 15 minutes minimum at a temp greater than 130 degrees, red light therapy, and cord plunge. All should be cleared by primary physician and should be monitored by an athletic trainer. Have patient meet with physical therapists once per week where as needed to help with injury prevention and coordination. Have patient work with mind memory drills, reading, and puzzles, crosswords, to assist with cognitive performance and maintenance. Patients should meet with dietitian to make sure they remain at a healthy weight and are incorporating foods for a healthy diet rich in antioxidants and proteins. Patients should meet with physician quarterly to assess progress of disease, progression of disease, and assess this disease prevention. Patients should ask about medications that could assist with disease mitigation. Patients should be educated, if not already has been, on the changes they may be going through. Caregivers should try to stay in contact with family, providing updates and encouraging patient to have conversation with family. A social worker should be contacted if not has been already. This is a additional case study for patient B. Patient B is a 65-year-old male with no current diagnosis of dementia or Alzheimer's. Patient B is concerned for his future health, considering family history. His grandfather passed after suffering with dementia, and his 76-year-old sister recently passed from pneumonia after suffering with Alzheimer's for 8 years. His currently living brother, age 58, is on dialysis. Patient exercises consistently throughout the week and was a marathon runner for 30 years. Has no history of substance abuse, mental health concerns, and has no current medical conditions besides type 1 diabetes. Patient has no imaging records for his current health concern and completed first visit with primary care regarding his concern last week. Patient has a strong diet following the Mediterranean diet and currently takes no medications besides insulin for his diabetes. Plan of action. Patient B is essentially showing concern for his future health, and rightfully so considering family history. Patient should get a script for medical imaging. Would suggest volumetric MRI, which is a MRI that measures the changes in brain volume, can reveal shrinkage in the medial temporal lobe. Would also recommend the tau PET imaging of his brain for a better analysis of his current cognitive health. Further, neuropsychological testing, cerebrospinal fluid analysis, genetic testing, and the Montreal Cognitive Assessment Exam should be performed. For the Montreal exam is a more sensitive test to evaluating patients with mild cognitive impairments. Patient's level of physical activity along with diet is more than sufficient, but still advise patient to exercise 3 to 5 days per week for 45 minutes at a moderate to high intensity. Focusing primarily on aerobic exercises with anaerobic incorporated, such as swimming, treadmill, dumbbells, and machines. Advise patient to use sauna for recovery and self-induced heat stress to reduce risk of CVD. Main goal through this is to improve and maintain cognitive neuroactivity. Educate patient on possible future daily living limitations he could face through AD if diagnosed, along with disease prevention and mitigation. Encourage patient to involve himself in social interactions, considering his lack of family available. This will assist with his psyche along with continuing to harness his cognitive ability and move. Provide patient with resources to maintain a sharp memory, such as puzzles, reading, crosswords, and writing. Encourage patient to perform coordination and mobility drills to maintain and improve neuroplasticity. Mention to patient that his diet is sufficient with providing the necessary macronutrients and antioxidant daily values. Advise patient on possible over-the-counter nootropics to assist with cognitive function protection. As one can see, Alzheimer's is a neurodegenerative disease that affects one's brain. It robs them of who they once were and changes their life forever and affects those around them. There are numerous genetic precursors that can make one vulnerable to this disease. There's testing involved for a proper diagnosis that includes imaging and memory exams along with cognitive function exams. There are also several factors one can take into account for prevention and mitigation through proper diet, exercise, significantly aerobic exercise at a high intensity to moderate intensity. Alzheimer's is one of the leading causes of dementia in the United States and is a growing concern as the population continues to get older and older. These are my sources for my photos used on this PowerPoint, and these are my sources for the context and information I gathered for my slides. Again, my name is Matthew Harkins. Thank you very much.